Hi, I'm Dr. Russ Skinner, founder of Superior Health and Wellness. I'm here today with Alicia Harrison, certified family nurse practitioner, who's one of our providers. And we're here today to talk about some of the new things in women's hormone replacement therapy. There was a lot of news last week with the removal of the black box warning for women's hormone replacement therapy, HRT, which really was very exciting for me. I remember being in residency where every woman going through menopause, we just said, you get estrogen just because it's going to protect your heart, it's going to protect your bones, all this stuff, and just everybody got it. And then the warnings came out after some of the studies that maybe that wasn't so great, and so then everybody kind of got leery about it. A lot of women said, oh, I don't want to do hormones because I heard they're bad. And now here we are removing that black box warning. It's kind of come around again. And I really think it's now opening up that opportunity for women who've really suffered with not just menopausal symptoms, which is really why they usually kind of call, but the long-term benefits of that hormone depletion.
Yeah.
What are you most excited about with seeing that black box warning removed?
Yeah. One, I think it just brought a lot of attention to hormone replacement therapy in the news that typically people wouldn't know much about. It hasn't been in the news for so long. And then to just empower women to bring it up to their providers when it hasn't been in conversation previously. Yeah.
It really is, I think, cool. There was an email that went out for those of you who are on our Superior Health Wellness email subscription. You got this email, and you can search that up under HRT. And for those of you who do not receive our email, you can go to our website, superiorhealthwellness.com, and look under our Learning Hub, and you'll see some of these articles that we're going to be talking about that have been published previously there as well. But, one of the, and you kind of mentioned it in one of your articles, is talking about the long-term benefits for hormone replacement therapy, particularly in women. Obviously, it applies to both, but what do you... For you as a practitioner, when you're talking to a patient about HRT, what's the biggest kind of long-term benefit that you see with HRT?
Oh, man. I think to back up a little bit, all of this conversation is a little nuanced because it's different for each woman that we're prescribing HRT for. So like you said, most of the time they're coming in for some sort of symptom, but for long-term benefits, one of the most prominent benefit that we've seen so far that's backed up by research is going to be like the bone density side of it, helping to prevent osteoporosis. And that's one of the pitfalls of aging and losing estrogen is that you're at higher risk for falls, for fractures, and estrogen actually can be quite protective for that. So you get that side of it, and then with your just symptom management, the sexual function, the vaginal health of your microbiome, sleep. Oh man, sleep. I can go on and on about how much hormone replacement therapy is beneficial for sleep, and some of the cognitive benefits of not only being protective for dementia, which there's some mixed reviews on like if it actually is helpful for preventing Alzheimer's, but if you are getting better sleep, deeper quality sleep, you're gonna have cognitive benefits, including, and this kind of falls into the brain fog symptom management side of just not feeling like yourself, having a foggy brain, and I mentioned in that article people describing it as lifting of a veil of a fog that they didn't even realize that they had at first. They start to become more like themselves. Yeah, what would you add to that?
Well, you mentioned the cognitive benefits, and there was some research done earlier this year looking at the role of estrogen in cognitive decline in men. For a lot of men that have been on testosterone replacement therapy, they were given estrogen or the aromatization blockers that would lower their estrogen levels. And they were just kind of generally prescribed. If you're on testosterone, here's your estrogen blocker. And it was the lower the better was kind of what everyone was told. And now we're seeing that no, that low estrogen is causing some cognitive decline, a little bit increased risk of earlier onset dementia. And now I'm telling patients, I know you are too, guys that you're on testosterone, you don't want your estrogen super low.
Yeah.
If your estrogen being high is symptomatic, then yes, you may need an aromatase inhibitor. But if it's not symptomatic, then the advice is to leave that estrogen alone. So just another patient group that shows that estrogen levels are crucial for helping protect us for mental decline, whether it's in a female patient or in a male patient.
Yeah, that's an important caveat to that too of, yes, men, estrogen is so important. I see people all the time that are so concerned about their estrogen being high. Not to get off on a little bit of a tangent either, but what are some other benefits of estrogen in women, and what are we actually trying to prevent long-term with HRT in women?
Well, there's definitely the decrease in cardiovascular risk, and that is somewhat multifactorial. When estrogen levels drop, we see a lot of truncal obesity. That central obesity starts to develop in postmenopausal women, and that is a cardiovascular risk. The other is poor sleep raises cortisol levels, which can lead to increase in weight, which can lead to increase in cortisol, or I said cortisol levels. Cortisol levels from lack of sleep and increase that can lead to increased weight. That increases cardiovascular risk. So there is that long-term cardiovascular risk reduction. Diabetes, obviously with truncal obesity and increased insulin resistance, the increased risk of type 2 diabetes developing, which has its own cardiovascular risks. All of that can go back to my hormone depletion.
Yeah.
If my hormone levels are normal, I don't see poor sleep, which doesn't raise my cortisol, which doesn't lead to weight gain, which doesn't lead to insulin resistance, which doesn't lead to diabetes. I don't get that truncal central obesity that can increase cardiovascular risk. So it's just amazing how many of those things are triggered by the decline in estrogen that we see at menopause.
Yeah, and it's so interconnected. I don't think that most patients know how crucial it is to not only support their body with lifestyle modifications, with diet to support their hormones and detoxification, but then at the end of the day, when they are aging and they do need help with the hormone replacement therapy, there's so many downstream effects of, we may not have the exact data to show one for one with hormone replacement therapy, but like I said earlier, with the sleep and the cognitive effects of it, there are just so many benefits, and the downstream effects are priceless in a lot of ways.
Absolutely. There, speaking of other things that can happen, most of those kind of fall in that metabolic profile. There's physical issues. I was at a meeting this weekend for training for a new device for our office in Plano that helps with musculoskeletal pain, decreasing inflammation in joints, and so on. And the guy that was doing our training sees a lot of musculoskeletal issues. And said that the biggest time where he sees the biggest increase in osteoarthritis of the knee is in women postmenopausal.
I believe it.
That they are doing fine. They go through menopause, and within a matter of years, they're showing degenerative joint disease at the knee, and most of it being hormonal, not just, but maybe some of it is multifactorial of increasing weight and so on, or they're tired and they're not exercising much, but a lot of it just direct hormonal effect on the health of the joint itself. And you're like, wow, that's a physical manifestation of hormone depletion right there.
I talk to patients a lot about this cycle that they get on, mostly with men and HRT and muscle mass, but this cycle that you can get on with, I have difficulty losing weight because I don't have the same amount of hormones that I used to, and then my joints hurt, and then I don't sleep as well because I'm not working out and my joints hurt, and then you get on this perpetual cycle of you're not able to work out like you used to, you're not losing weight like you used to, and you're not sleeping well. And once we break that cycle somewhere, and an option is with HRT and estrogen therapy, testosterone therapy, things of that nature, that the cycle is broken, and then you start sleeping better, and then you have more energy to actually work out, and then you gain muscle, and then you start losing weight because you have muscle. And I think that kind of leads into some of the other things that we were going to talk about as well.
Absolutely. It really is interesting how much begins to overlap if you really start looking at that. You're right, that cycle of this thing happened and then that thing happened, and because of those I can't do this, round it goes, and it really is a big deal to kind of break that cycle. It's interesting you mentioned joint pain. I can't tell you how many guys have come in on that start testosterone, and that's one of the first things they report. I mean, they usually think, oh, my libido's gone up and whatever, but they go, my joints don't hurt like they did, or I'm sleeping better. Those are two that really come on fairly early. Is that we talked on kind of brain health and improvements there. We talked about metabolic balance that comes with hormone replacement therapy, and you mentioned it too at the very beginning, talking about the how everyone's a little bit different and the importance of personalizing that plan. And I know at Superior we really focus on, look, we're taking care of you. We're not taking care of everybody. At least in this visit, we're just taking care of you. And so what are your goals? What are your symptoms? What works is going to help alleviate those problems for you? What dose is right for you? How often do we need to check? I know you get that question, I do too. You know, how often do I have to check my hormone levels? And it's like, it kind of depends on what your hormone levels are doing.
Yeah.
You know, early stage where we're making adjustments, we may need to check fairly often. If you prove that, you know, your dose is really stable for a period of time, you know, a couple of times a year may be adequate, but you don't really know until you see how people respond.
Yeah. And I think that was one mention in one of the articles was it is so individual, and being mindful that stress is going to change your hormone levels. If you go through a really traumatic event in your life, if you move, if you're not sleeping well because of the stress, if you're not eating as well as you used to. And so even if you are stable, there might be a conversation that you need to have when big lifestyle and life factors change as well.
Very true. People don't, I know, I wouldn't have thought about, you know, how much my dietary change would affect my hormone levels, but it can. And so, you know, we're remodeling the kitchen, and all of a sudden we're eating out a lot more. We're eating differently. We're not cooking at home. That can make a difference. You know, I had to have surgery, and I'm recovering from that, and I'm not sleeping as well. That can have a negative impact on those hormone levels. You know, thinking about individualized care, the most common thing I see as far as a mistake that people make is getting overdosed. Not intentionally, but they just end up taking too much. Well, this is what everybody gets, so this is what you get, and then they come back, you know, in 6 months, and their levels are wrong, like way wrong, and then you've got to correct that. And so, in addition to just kind of dosing issues that may occur places, what do you see as some other mistakes people make with hormone therapy?
Oh, man.
Not just providers, which that is kind of its own question, what mistakes do providers make, but really is kind of, is the patient receiving HRT, what do they do wrong sometimes that messes things up?
Oh, man. I don't want to get too picky for a particular subset of patients, because in general, there are people who really want help and are good and respectful at listening. There are times, though, it's just specifically with dosing. I know that you've already hit on this a little bit, but not staying open to that there is a time and a place to change doses. I do see patients coming in and saying, like, this has been my dose for so long, I don't know why you're changing it. So staying open to that, staying in an open conversation with your provider. And there are, like you said, there are providers who, do a one-size-fits-all, or they just don't listen to your concerns, and they want to be as safe as possible, don't want to push any boundaries, especially when it comes to changes in levels that they're not comfortable with. So keeping an open conversation and respecting your physician's training. There's a lot of misinformation out in the world right now when it comes to targeted levels, and then fixating on what their levels on the labs look like. I think that can be a mistake on both sides as well. So one person may have their symptoms relieved and then see the benefits at testosterone of 750, and others may not see that until closer to 800-900. And so not being fixated on, I have to meet this range.
Yeah, that's very true.
Yeah, that's probably one of the bigger things that I see in patients, as well as not following up with lifestyle. And you'll hear me just harp on that pretty much all day long. But there's got to be a change in the cycle. Like I said, there is the HRT side of it, but are you sleeping well? And is that sleep related to hormone replacement therapy and the lack of testosterone? And we're kind of talking more about men at this point, but it's similar for women as well. Or is it sleep apnea? Like staying open to that. It's not always a hormone problem.
That is very true.
But it can lead to a hormone problem.
That's true
So
too.
if you have obstructive sleep apnea, you're not getting good restful sleep. You're not going to produce the testosterone that your body is made to produce during deep sleep. And so you're going to have this perpetual cycle of, if we just treat the sleep apnea, we don't get so fixated on the testosterone, because you may not see a lot of movement even with testosterone replacement therapy, and you're leaning way too much into the hormone side of it, and it's valuable and so important. And that's why I appreciate that the black box warning was taken off, because it really has put an emphasis on, like, these are important things for long-term health, but it may not be the end-all be-all for you. And so you need to be discussing with your provider of what the benefits are for your specific case, and what you may see versus other people when it comes to like dosing and corrections of hormone therapies. So.
I like how you mentioned that not thinking everything is hormonal, because, and I have these conversations with patients as well. You know, the symptoms of low testosterone, for example, if I'm talking to a male patient, are fairly general, and you know, it's fatigue. I don't sleep well. My concentration's off. I don't have a lot of motivation, and I'm going depression. I mean, those could all be depression, which affects weight, affects sleep, affects energy, motivation. All these things could be depression. And so there's a lot of things, you know, especially for our male patients, it's kind of hard to come in and say, Doc, I think I'm depressed. It's easy to come in and say, my guys are all on T, and they said they felt terrible, and I think that's me too. So sometimes that's an easy conversation to say, well, let's check your hormones, see where we are. And then you come back and go, well, you know, your testosterone looks pretty good. You know, these symptoms could also be signs of, you know, depression or some other underlying problem, a thyroid disorder, particularly in our female patients where thyroid's much more common, you know, can look very similar to where our hormones are. Now, hormone levels that are low on labs are low, but at least listening to those symptoms, I think patients and providers sometimes get fixated on, you know, this is your hormones, when there definitely are some other things that could be there. There was an article you wrote talking about kind of common pitfalls, and one of the things you mentioned was kind of the unrealistic expectations of when am I going to feel better, and I loved how you really put that into perspective, that, you know, there may be some things you feel right away, but it could take weeks to months to really start saying, okay, things have balanced out, I'm really feeling good now. You know, for our women's HRT, what are those kind of, you know, for men it's easy. Testosterone usually, my energy's back. You know, they're feeling good, or their libido spikes really quick. But on the, you know, on female HRT, specifically thinking about estrogen and so forth, what are some things that they would see fairly early on before everything is necessarily balanced out?
I mean, even with estrogen, you see a pretty good spike in energy levels. It's a driver, and so maybe not to the same extent as testosterone is going to be, but I've heard that it's called the girl boss hormone, and I hate that, but there is an extent to it. If you have a good, healthy estrogen level, you are going to be more inclined to have a drive of some sort or fashion. So similarly, I see a good boost in energy levels, balanced mood. Oh man, that's probably one of the first things that people usually say that they have an improvement, especially if they're on progesterone therapy as well. I like the oral progesterone at night, specifically for those mood and cognitive benefits of progesterone. And so that's probably better sleep. So a lot of the like neurological and cognitive benefits symptom-wise is probably what I see the most quickly in women's health. What about you?
Nice. I would say very, very similar. Hot flashes get better really quick. So somebody that's in that perimenopausal period, obviously hot flashes improve, which can improve sleep. The moodiness, the kind of that really, I think that's probably one of the earlier ones.
Yeah.
Obviously, long-term benefits, cardiovascular bone, that's all down the road stuff. But yeah, I agree with you. That kind of mood improvement or decrease in moodiness really does improve fairly quickly within a matter of weeks. And I think making sure our patients, are aware that, hey, this isn't going to be overnight, but it's not months either.
Yeah.
A lot of those things they really are complaining of happen really pretty quick.
Yeah. Well, thank you for bringing up hot flashes. That one just kind of went to the wayside in my brain. But that was part of what the FDA was talking about, was that estrogen, at the end of the day, hormone replacement therapy with estrogen and then progesterone, if you have an intact uterus as a woman, are the most beneficial for those vasomotor symptoms like hot flashes. And so at the end of the day, there are some good pharmaceuticals coming out, but hormone replacement therapy goes beyond those symptoms of the hot flashes and vasomotor symptoms that patients are experiencing.
It really does. One of the other, and we've mentioned several times, of kind of the weight gain that we see around menopause. And obviously people can have weight gain for multiple reasons. And there are some really good, medications for weight loss, specifically our GLP-1s and similar, that can really be effective for weight loss, particularly definitely if someone has diabetes, if their weight is, in the 30 to 35 BMI range, where GLP-1s can really be effective. Have you noticed an improvement in, and I know you're going to reference a study, have we seen some benefits to where HRT works in, symbiotically with GLP-1 therapy?
Yeah. I mean, you mentioned it earlier that there is this downward effect of the increased adipose tissue of the midsection that does put you at increased risk for insulin resistance, which is when the blood sugar isn't actually able to make it into the cells to use for energy. That can lead to diabetes and other metabolic disorders. So this was actually a retrospective study, and I'm just going to read off of my screen. And this was talking about tirzepatide, which is actually a mix. There's the GLP-1s, but then there's an added benefit of the GIP. So tirzepatide is also known as Zepbound, and that one specifically is FDA approved for weight loss, correct?
Yeah.
But with women on HRT, they found that HRT alongside tirzepatide, or the blended GIP-GLP-1 antagonist, lost an average of 17% of their body weight compared to 14% with those that were not on HRT. So there is a significant benefit to body weight loss or fat loss for women who were on GLP-1. Additionally, 45% of the women in HRT group achieved at least 20% weight loss versus 18% on non-HRT group. Importantly, the study found that no evidence of HRT hindered weight loss. Instead, it appeared to enhance the metabolic benefits of the GLP-1 therapy. And as we mentioned a while ago about the insulin sensitivity, I mean, estrogen improves insulin sensitivity. And then if you get on that good cycle of I'm losing weight, I'm losing fat, have better insulin sensitivity, yes, absolutely. There's a synergistic effect of a medication that makes you more insulin sensitive, and then also benefits you with managing your insulin levels that can actually contribute to holding on to fat and making it more difficult to lose weight in the long run. So that's the first thing that I think about is just insulin sensitivity in general that worsens as we age. Specifically at menopause, there's just a big jump or leap in the worsening of insulin sensitivity for that.
Very much so. And those percentage points for the layperson listening, they probably don't sound very, very big, but those are significant percentage points.
Yeah.
I mean, those are statistical. When they do these studies, they look for statistically significant. They've determined that it made a difference. I mean, that 3%, everybody, 3%, what difference is that?
Yeah.
Well, it kind of depends on how much weight you're trying to lose. If you're trying to lose 10 pounds, it's another pound. But if you're trying to lose 50 pounds, it's another 5 or 6 pounds. And you're like, well, that's a big difference. That's your cushion for a little bit of weight regain after therapy.
Yeah.
I got there plus a little bit. In the other, which we're not blind to, is these medications are not inexpensive. So the longer you have to be on these medications to get to a goal weight, the more it's costing. And so a medicine that's more effective, or if you're on, you think about HRT and you need to be on weight loss, being on HRT and then starting your weight loss medication may really help your weight loss, which minimizes how long you have to be on that GLP-1, how fast you're going to get to your weight loss goals, how much money you have left over for Christmas. I mean, these things are real world. That makes a difference for people. So it's really neat to see how well those work together. I don't think anybody necessarily thought you can't be on them at the same time, but to see that besides just it's okay to take them both, it's better to take them both can really says a lot, I think, for those groups. We mentioned talking about some of the men's HRT earlier, and we were talking about kind of the pitfalls and mistakes that sometimes we see, specifically in HRT, but we were kind of focused on our female patient. And our male patient, the big problem, the one mistake I see people do, and people come in with it, is testosterone alone. They only do testosterone. Now, I think that there's an age where that may be appropriate. An older guy, granted what I consider older is getting older and older and older as I get older, but an older guy that's, seeing his testosterone boost, needs a little lift, he's been done having kids, he's not really worried about that. I'm usually pretty straightforward with patients. I'm like, look, if you're 65, you're probably looking at being on hormone therapy for 10 years or so, not because you couldn't safely be on it longer than that, but we're 75, we get tired, we're not doing as much, my hip bothers me, whatever it may be. So, but our length of time under treatment is very different than that 35-year-old that comes in. That's testosterone levels are low, may still want to have kids, and not offering those guys something to help boost natural production of testosterone, which maintains fertility. So I know HCG is one of those things that I really think we should probably be talking more about for those guys coming on, particularly our younger guys on testosterone therapy. Where do you see the importance of HCG in that crowd?
I think that you made a good point. The differentiation between being on testosterone for a short amount of time as an older man and being on it for a long period of time as a younger man. I mean, risks are going to increase as you are continuing therapy. But I think that some people don't even realize that when you are on testosterone replacement therapy, you are suppressing your own natural production of testosterone. So if you're that young and starting testosterone, one, you are suppressing your own natural production of testosterone, which is already sounds like it's low, which I always have questions about. But HCG does give us an opportunity to potentially give an option other than testosterone by itself or even as a therapy, because HCG can be used for men alone.
Absolutely.
But I think that if they were coming in with testosterone already, natural production of testosterone is going to be suppressed, and then also you're going to have decreased fertility because of the testosterone therapy. And so, HCG can be used in conjunction with testosterone to boost sperm production and to maintain fertility in men that are on TRT. Words are
using
hard.
TRT.
Are taking testosterone replacement therapy. But I think it's a valuable place to start too if you do have a 30-something-year-old who does have low testosterone in labs, is having significant symptoms in conjunction with some of the other lifestyle and dietary factors that can contribute to low testosterone. And so, the fertility side of it. And then from an aesthetics perspective, some people, they experience testicular shrink, and that doesn't suit well with them as a 30-something-year-old. And so,
this is true.
And we have to talk about it because that is, I think that the mental side of it can have an effect on further downstream effects of relationships and overall satisfaction in life. And so yeah, that's that subset of the 30, 40-year-olds that I think that is definitely a valuable tool for that.
And you mentioned it as first line, and I think there's a lot of patients out there, there's a lot of stuff out there, obviously, about testosterone.
Yeah.
TRT, T-clinic, men's health, and it's all testosterone. And HCG is great first line in that young person. You know, they're still making testosterone. They just may not be making enough, and that HCG can really boost that. The article we have on our site also doesn't mention it in that particular article, but clomiphene is another really good option to help boost that natural production of testosterone in that younger patient. Sometimes that's all they need. I've seen HCG or clomiphene, either one, boosting somebody's total testosterone by 200 points. Well, somebody that's, you know, just kind of not feeling great, their level's 500, a boost to 700 is a big jump. Now, if they're at, you know, 100, then 200 gets them to 300, and that's still pretty poor. But there's definitely that group there that it can work all alone. And for guys who are maybe, you know, don't like needles, don't want to do shots, clomiphene is a tablet. You know, HCG is a subcutaneous injection, so if you're used to those testosterone shots, it's a big shot in the backside. These are not. These are little shots. And so they're very well tolerated by people, and I think, and I would encourage all our guys that are on testosterone or thinking about testosterone to go to our Learning Hub, read this article. I think the title of it is, I'll actually pull it up here, Human Chorionic Gonadotropin HCG Therapy for Men. It's a really informative. It even talks about how you can rehab suppressed testosterone production with use of HCG. So that's the guy that's coming, he's been on testosterone for 10 years. Nobody ever told him it's going to suppress my natural production. And now I kind of want to come off, but when I do, my T level drops to nothing. And they're like, I'm just going to have to be stuck on testosterone forever. Not necessarily. There is a protocol to rehab you through that, so your body does get back to making testosterone.
Yeah, and as you were talking, that was one of the other benefits of HCG that I was thinking about, is if for those men that they just don't want to be on the full effect of it anymore, or they've been on it for an extended period of time. And I've seen some benefit in. There have been controversial conversations about, is cycling testosterone actually more beneficial than being on it for a significant period of time, no stop, but you know, that's a whole conversation. But if a man has been on it for an extended period of time and wanting to wean off of it, it's super helpful. And going even back to the GLP-1 and weaning off of that, what are ways that we can support the body to tolerate that better? And there are ways. I think that's an important thing to say, is that you aren't just free floating and having to like jump off of something. Work with your provider, and I think that I think Superior is set up well to where providers know their patients really well, and then also can have those conversations of, okay, now that you want to be off of it, what are ways that we can wean off of it in a healthy way, and also with the suppression of testosterone production, then that there is a physiological need for it, or you're going to be left out, stranded out in the ocean with no testosterone to support your body.
That's right. That's right. And I like how you talk about weaning off. You know, people will ask, you know, how long do I have to do hormone replacement therapy? And the answer is, I always say this kind of tongue in cheek, but it is as honest an answer as I can give, until you don't care anymore. Now, that doesn't mean negatively, but it's like there does come a point in all of our lives where it's like, you know, the benefits I was getting from testosterone therapy or from HRT, those just aren't big lifestyle needs of mine anymore. You know, I'm an older person now. I have lived long. I'm not as physically active for whatever reason there may be. Sexual health may not be an important thing for me, depending on if I still have a partner in this world or not. And so a lot of changes, we forget that, you know, that we all live down this continuum of time, and there is a point in time where at, you know, my age, or where it's like, it's important. I want to be physically fit. I want to prevent heart disease. I want to be, you know, vibrant and have a lot of all these things. But I can look ahead and think, you know, all right, well, am I still going to feel that way when I'm 70, when I'm 80, when I'm 90? when I'm pushing that centurion mark,
Lord willing.
is, how productive I am in the gym going to be all that important to me, or is it the fact that I could get to the mailbox going to be important to me? I don't know. Hopefully it's, can I still get to the gym?
Yeah.
But we all are going to reach that point, and when we start saying, I don't know that this is something I want to continue, that the answer isn't, we'll just stop. That there are easier ways to come off of this. I think specifically HCG for someone coming off, that could continue to support them for a period of time and not be as aggressively hormonal. And then maybe even weaning off of that. And like you spoke to with the GLP-1s, when you reach your weight loss goal, the answer is I can quit now. If you're on a very low dose and have been on a very short period of time because you just needed to drop some weight before an event, for example, then yes, you might be able to. But someone who's had a significant weight loss journey and has lost a lot of weight and has gotten to a maximum dose of a GLP-1, they do not want to stop abruptly. They really want to wean off some way, shape, or form, or move to some sort of maintenance plan. So it's interesting, and I liked how you said, talk to your provider. We're here, we're resources. We want to partner with these kind of therapies long term with people. That's why we do this. And so I think our patients we need to continue to encourage them, come back. If things have changed, if something's different, we may need to tweak things a little bit.
Yeah. Absolutely. And you alluded to earlier about, like, you may need to follow up with your provider more frequently at the very beginning, and that's okay, because in the long run, it's going to benefit you and the patient-provider relationship long term of, like, how well did we actually prep you for long-term benefits? We didn't just start you on one dose and leave you there for years to come. So, you're going to end up seeing greater benefits when you follow up with your provider. So that's a little push towards for patient-provider follow-up and relationship there.
Absolutely. Well, Alicia, this has been a lot of fun having this conversation. I mean, how important it is for our patients to hear that those warnings regarding HRT have been removed. It kind of opens the door. Maybe I don't need to be as concerned. There still are patient groups that do have some concerns. We kind of didn't touch on that. That may be for some later of, who shouldn't be on hormone replacement therapy. And there are some people out there that fall into those categories. So just know is if you're listening to this, talk to your provider, because there may be some things specific to your history or your family history that would preclude you being on HRT, and we want to make sure everyone realizes that there are some people that don't qualify or should not maybe be on hormone replacement therapy. But it's still exciting to see those warnings removed, to see how there are some long-term as well as short-term benefits to HRT, how well it can work in conjunction with your weight loss journeys. And then, for our male patients, a little plug there at the end of, look, if you're a young guy, you're concerned about your natural production of testosterone, HCG can be really key to that, and may even be your first-line treatment, and that's really a good reminder. So I have enjoyed our time so much. I look forward to us doing this again. Anybody that's listening, please go to us on superiorhealthwellness.com. All the material, the articles that we talked about are available on our Learning Hub. And if you're receiving this email already, if you're receiving these emails and didn't read that one real close, go back and look, because there's some really good information there. And we look forward to doing this a little on the more regular. And thank you again, Alicia, for being here. I really appreciate it.
Thank you, guys.